Anyway, we're going to try to wake you up with some excitement. Complications during left atrial appendage closure, which may occur to you despite your best efforts. But here's some, I think, breaking it down by sort of components of the process between patient selection and the procedure and getting down to where these issues are. One of the main things that you can do to avoid complications is not pick patients that are high risk for the procedure. Now that's kind of hard to do when it comes to left atrial appendage closure. This study came out last fall, I thought actually really nice. Looks at about 1,000 patients done at a center where if you had major bleeding in the first year after your left atrial appendage closure device, you had a significantly increased risk of what's called early death, death within a year of the procedure. So the highest risk bleeders are the people that are going to bleed. They're also the highest risk for dying within a year of getting the closure device. And then when you actually break it down by certain sub-categories and look at making kind of a predictor score in terms of the risk for early death, if you're over 78, BMI less than 23, diabetic with renal insufficiency, and a prior history of heart failure, you have a 49% chance of being dead within a year. Okay, so that's very important consideration when choosing the patient before you put them under general anesthesia and an hour or less invasive procedure. Now, what are the little unique components of left atrial appendage closure that are complications that we need to be aware of? I think the Watchman data really sort of set this out first, where they broke it down with access complications, pericardial effusions, of course, stroke from an air embolism, or acute thrombus formation during the procedure, device embolization, and then in some ways device leak or thrombus, which are really more of a side effect, I suppose, of appendage occlusion. So from the NCDR registry, Watchman 2.5 data, any major complication is 2.16%, and so it's going to happen. 1 out of 50 patients are going to have a major complication. I mean, that's across operators, physician annual volume, makes some impact on that, but probably not a whole lot after you get past 30 or 40 cases, and I think the vast majority of you doing amulets now even have had more amulet implants than that. The SurePass data does show a progression, though, where we're getting safer, the devices are getting better, and hopefully we can target these kind of numbers also eventually with the amulet system, which would be sort of a less than 1% major adverse event rate from implant. But that being said, it's not 0.0, so let's look at some examples of things that can happen. From the Amulet IDE trial, this is buried in the appendix tables. You have to go back and find it. But the actual pericardial effusion tamponade greater than 2 days post-procedure, there was 10 in the Amulet group, 1 in the Watchman group. So you have to be aware when you send the patient home, same-day discharge, next day, you might want a phone call follow-up from your appendage coordinator just to check on them a few days later, make sure they're not having shortness of breath or chest pain 3 days post-amulet. Device embolization was a little bit more common. I think that's probably balanced out now just with operator experience. The pericardial effusion rate in the Amulet trial seemed to drop as we got more effective and more experience with the device, but also changing the post-implant drug regimen at least helped in reaction to a high bleeding rate in the early parts of the trial. So this is still kind of up for debate, what's the optimal regimen. But certainly, you're maybe more likely to get a pericardial effusion if you are anticoagulated. Now, what do you do with DOAC? When do you interrupt it beforehand? And how systemically anticoagulated is the patient apart from your heparin bolus during the actual implant? That may affect probability of a small microperf, amplifying itself and ending up with pericardial effusion and tamponade on the table versus showing up a week later. From Emerge LAA, we do have data that's in review. We're up to over 5,000 patients now with the Amulet device. We can see the orange bar is the Amulet IDE trial complication rates, and so the real-world practice is actually improving quite a bit. Primary safety endpoint has kind of dropped in half, and markedly fewer device embolizations, I think, as we get more experience with it. Vascular access complications, everybody's at risk for this when we stick a needle in them. They're at risk for it twice when we do an ice-guided procedure. It's the most common complication reported. It's usually people think of it as a minor complication, but that is not always the case. How you close the groin may or may not really affect that, apart from, I would say, probably off-label use of Vascades. I don't generally recommend that, but I typically do a figure of 8 closure, but a per close or manual pressure is certainly acceptable. In general, we try to avoid femoral arterial access unless anesthesia really is hammering you about that. So here's a patient I was doing in the Champion trial. Little old lady, low BMI, 20, kyphoscoliotic, swan-shaped posterior rotated appendage, not going to be a fun case. Ultimately, I was not able to successfully implant her. I ended up deciding to abort the case, and she was tolerating anticoagulation, as all the patients in Champion and Catalyst were, and then brought her back to the holding area, and maybe 3-4 hours later, she starts complaining of abdominal pain. And so I think this is an important thing. I use a long sheath, like a Cook sheath, 16 or 18 for flexes, 18 for amulets, sometimes a dry seal sheath on all my cases. So in general, I've got sort of a protected entry point up to about the mid-IVC, I would say. But then, there's this space, right, above the sheath, and sometimes the tip of these sheaths are fairly stiff. You've got stiff wires and a catheter, and you're really not imaging that area at all during the procedure. You don't see below the heart, really, by TEE. Well, she ended up having basically a small tear in the IVC above where the long sheath was, and a big retrocardiac hematoma that spread into her pleural space. So just because you ultrasound image the groin and use a long sheath, this does not prevent you from an access complication before you actually enter the heart. Now, once you're in the heart, we're talking pericardial effusion. So that can be caused by any number of these objects that we put in people: transseptal puncture needles, stiff wires, sheaths, and then the device itself. In general, when I find a patient has like a really hypercontractile, one of those appendages that just obliterates the cavity with systole, and they look also volume depleted, I would tend to talk to my anesthesiologist, I give them a little volume load, and then also hit them with esmolol, and just try to chill the appendage out, like take the contractility down. You might even consider breath holding. We used to do that all the time in Watchman 2.5, but it's something we barely discuss that anymore with flex or amulet implants, but it can be quite helpful. Specifically with amulet, when we start going to ball, one of the key things is I guess the pre-ball shape is pretty firm. So you don't really want to pre-ball up against the appendage. You could certainly see that as a cause of a potential perforation. So in general, watch that. I usually watch it on TEE in the biplane while I'm going to ball to make sure that there's nothing in my way as I start to unsheath and form the ball in the sort of proximal neck of the appendage. But these are things, and certainly don't, I would say one of the things about effusion management, if there's a sheath perf and a device perf, something big, probably that's one of those where I had a neurologist that told me, don't just do something, stand there. Don't overreact immediately, and your tendency is going to be like your hand's on a hot stove and you rip the sheath back out of the heart, and now you got a hold that's really a problem. So if you can recognize a sheath perf before you pull the sheath out, you may have a chance to at least have some other options non-surgically. But always having a surgical backup plan is important. With Watchman 2.5, here's an example of just angiographically where we can see the feet of the device creeping out past the pericardial border, and then the shape of the distal part of the Watchman 2.5 was pretty odd there. We then see contrast extruding out into the pericardial sac. You could see this on ice. It's probably not great if your anesthesiologist is the one that tells you the patient's in tamponade. Ideally, they tell you, hey, I think I see some fluid, let's take a look. Try to pick it up beforehand, and then make your decision about whether you're going to reverse anticoagulation, auto-transfuse, or call the OR depending on the scenario. You're not always entirely sure where a small effusion comes from, though, unless you really know that it wasn't there at baseline. So it's very important to have that baseline TEE image so that you know there's no effusion. Now, sometimes we'll get aggressive with devices where you would think we would cause a pericardial effusion, like example A and B here. So on the left is an amulet that's just crushed the lobe, and this is a Watchman flex where I had some weird anatomy and I was sub-selected and ended up just creating like a whole new shape. It's like beyond the hot dog. I don't even know what that is. But these are cases where, boy, I mean, the amount of pressure we had up against the wall the whole time, the only thing that kept these two patients maybe from having a pericardial effusion is the presence of those nice sternal wires that we all like to see. Now, doesn't mean you won't have an effusion, but here's a patient, a catalyst patient that I did. Pretty nice. You can see the pulmonary artery away from the left atrial appendage there in the 135, a little bit of transverse sinus space, and a reasonably thick amount of myocardium for device placement. So we go in and get the amulet in place, and you can see my lobe angiogram looks pretty tight. Maybe just a little squirt around the disc, but we're thinking, yeah, that's probably a little cable bias. When we release, the disc should flush, occlude that and be good. And she does fine. The device post-implant looks great. No leak. Post-implant TEE right here, no pericardial effusion. Post-implant echo, surface echo, per the trial, that's actually sort of like lung and pleural space, not really an effusion there in the first 4 clips. But then 3 days later, she comes back with shortness of breath and chest discomfort, and there we go. So there's a delayed pericardial effusion with early tamponade. Now, one of the key things, of course, is managing that. So the number one thing that I've seen, reviewing cases and whatnot with LAAC where there's a patient death, it's almost always from inadequate rescue from pericardial effusion. So just be mindful of that. Like managing that is the most important thing. How do you manage tamponade? I mean, hopefully we all have experience with that. Unfortunately, it's sort of a good and a bad, right? You have to have experience with it to be able to manage it, but then you don't really want to have it happen. There's not a good simulator for that. 90-day post-amulet TE on her actually looked perfect, and everything was great. Now, why did that cause a pericardial effusion 3 days later? It's still kind of scratching my head a little bit. We've looked at, in the literature, you'll find case reports of these where the pulmonary artery is thought to be like compressed and adjacent to a thin-walled left atrial appendage, and perhaps the anchors are getting in there, poking, causing pericarditis, causing pulmonary artery injury or something like that. She really had pretty good amount of space around and a clear transverse sinus gap between the PA and the appendage, so I'm still not entirely sure why that happened. This is one of the things, though, you could anticipate as a possible risk is the cuddling lobe orientation, we call it, where if the entire sort of side of the lobe is looking like it's going to be flush parallel to the wall of the pulmonary artery on 135, like throughout its entire shape, that may indicate a somewhat higher risk for the late device-related pulmonary artery injury. So on occasion, I have seen patients where I go in and look at the TE and the appendage looks really thin, the PA is big and right up next to it, and they're frail, and I may opt to switch to a different device. So avoidance is key, but managing it is also key. One good thing that the lariat taught us, apart from the fact that, I don't know, we were kind of crazy gaga about removing the appendage and all of a sudden AFib would go away. But we did learn how to do dry pericardial tap really well. And for epicardial VT ablation, physicians, that's also a really important skill set. I feel like probably the interventional cardiology group doesn't have much experience at all with doing dry pericardial taps. Mostly you're going to be doing it in the setting of a pericardial effusion that's pre-existing. But we have learned a few interesting things with CT and placing drains. So when you do a stick to rescue someone from tamponade, remember there's risks to sticking under the sternum too. So don't scrape the liver, try to stay midline, get underneath. I generally recommend the substernal approach, so rather than a posterior stick. But with that, sometimes you can nip a branch of an epicardial superficial epigastric artery or a branch of the lima and end up with bleeding from the drain and the stick. So just something to be mindful of. Every reaction and everything we do to treat a complication can create its own complication. What about device embolization? So here's a nice flex that I put in a while back, had a nice little chicken wing shape. I thought it was perfectly situated in the neck, really by TE, it looked really good. By 90 days, you can see that device rotated out and migrated quite a bit. Still occluded, interestingly. You can see how fibrotic it is or as Dr. Chirac mentioned, I really like that. This is the expected tissue ingrowth into the device. Now, Watchman 2.5, I think, was more prone to embolization when it was going to move or migrate, as opposed to flex, where it seems to migrate and just sort of stay put. So, you know, with 2.5, we'd have to often go in and take, not often, but occasionally have to go in and take one of these devices out if we didn't like it intraprocedurally, or if it embolized. On occasion, I'd see a patient come in 45 days after implant with the device, you know, in the distal aorta. So here's an example. This patient was in the Amulet IDE, one of my patients, and sure enough, we try to get cute with measurements. We've learned a lot since then. This was in 2016. There's a little bit of an edge to an ostium on the 135 view, but that's where we measured it at 17 millimeters, and we put a 21 millimeter device in there. But you can see this thing is like a giant water balloon below it. There's a huge amount of volume in that appendage and a lot of potential space. We should have oversized this device big time. But sure enough, he comes in for 45 days, they can't find the device. It's down in the distal aorta, no symptoms. So femoral artery retrieval of these is not too bad, I think. We'll generally engage our interventional cardiology colleagues to give us a hand if we see that. But if you can grab a Watchman 2.5 pretty much with any open-end gooseneck snare and pull it through a stiff, you know, maybe a 14 or 16 French sheath, and that'll come out without too much difficulty. Here he is in his explanted state. Unfortunately for this patient, the funny thing is actually then I went back and put a 27 Watchman 2.5 in, and on release, as we used to get a lot of times, you'd see the device move when you let it go, and sure enough, it just like snatched and retracted under there, and now I gave him a leak. So anyway, but don't be reassured too much. Embolization is like agnostic to your device, so this can happen with Amulet too. And what are some of the things we want to watch out for there? Device is too small, not compressed. Changing dimensions of the appendage measurements during the procedure where you feel like there's a lot of dynamic change because the volume loading state is affecting your measurement. If it's off axis or if we do too vigorous of a tug or wiggle, that's a problem. And overcompression is a problem. So again, when we get in and we're checking the lobe, we don't really want to push the cable when we're doing a tension test for fear of destabilizing the wires, and try to avoid that wiggling movement that I showed earlier with the Watchman flex, because that tends to destabilize an Amulet. But if you really are careful with verifying the closed criteria, I think generally embolization risk now is like well less than 0.5% and hopefully heading towards, you know, a rare event. The tools you might need could include definitely you need a large, long sheath, something you can use as a buttress against the device to pull it in. But with Amulet, you also have to have a really good grip on it because it doesn't have an open-ended, you know, leg to it really. So you can try to snare the distal end screw. You can pop a coronary wire through the device and snare the coronary wire. You know, I don't know, I haven't really seen any good examples of Raptors being used for these. I think you may end up heading to surgery a little bit more often with this than you would with an embolized Watchman. It just kind of depends where it gets stuck. So here's an example where the device was too proximal, ended up shifting and ultimately embolizing to the distal aorta. Very similar, grabbed it with a long 16 French gooseneck snare at the distal end screw and pulled the device back out. Acute thrombus can occur during the procedure. That's pretty unusual in these days. We're pretty aggressive about anticoagulation. But here's a nice case where I'm going in and the patient is a conscious sedation, ice-guided implant, and sure enough, he's big old belly, he snorts about who knows what, a liter of air while I'm trying to get the pigtail in. And I mean, that's within just like a second, just opening the valve for a second. Basically, his whole cardiac function ceased to flow. I saw EKG changes I have never seen in my life. Pretty impressive, actually. And basically, it looked like a sack of grapes. You can see it's like soap bubbles right around his aortic root here. There you go. So we want to watch out for that. We did CPR, put him on ECMO. I just happened to have a transplant surgeon and an interventional cardiologist walking by with ECMO cannulas, and I'm like, hey, here you go. Got, you know, this is, well, it's one of the good things about being at a heart transplant center. So we got him through this, and then he was actually perfectly fine neurologically, brought him back 3 months later, I had a good relationship with the patient, and he was happy to let me do it again under general anesthesia. Last thing I'd say just about intracardiac thrombus, I haven't seen it happen acutely. We all talk about the disc being tucked down under the PV ridge limbus as more of a chronic DRT risk, but that's certainly someplace you want to probably investigate that carefully if you see this during the procedure, and then be mindful that that could form a nidus for one of these DRTs later. Most of the DRTs that I've seen with Amulet tend to be sessile bubblegum, remnants, as was mentioned, which I like. That's a good analogy. The Watchman ones tend to be a little bit more pedunculated and mobile, I think probably because the more irregular surface of the device. I'm going to skip that. The last thing about complications really is leak avoidance, and I think that's kind of a different talk, so I'm going to kind of skip that. But a lot of that's device anatomy mismatch. And so I think the more options you have as you get really facile with using Amulet, you can probably avoid these kind of situations with a Watchman and not have to mess around with bringing the patient back for device leak closure. Although apparently Dr. Horton is available for consultation if you care to send him any cases. So LAC complication management summary, these are the main points I think important to be mindful of: patient selection, things you can't see like vascular anatomy between the femoral vein and the IVC, and being real mindful about prevention of air embolism and management of pericardial effusions. Thank you.
So my topic is how to avoid complications. If you do enough, you're going to have some complication, but certainly we can minimize the complications. So the people who are relatively new to the appendage occlusion or new to Amulet, the first thing is in pre-procedure. You have to look at the TE picture yourself. It was discussed that, your rep may not be very experienced, your imager may not be very experienced with the Amulet measurements or with the left atrium. In general, it has tough views. You need to look at all the cardinal views, 0, 45, 90, 135 yourself. So you can have an image, what type of appendage it is, what type of shape it is. Is it a common garden variety one, which is easy to close, or it's one of those ones which are complex, like anterior chicken wing, very shallow, a broccoli-shaped appendage. Also, we have talked about a lot about left side of the brain, right side of the brain. It's important to know that you need to plan the procedure in your mind, that what is the orientation of the LA, what is the shape of the LA, what is the adjacent structures, how far is the mitral valve, where is the pulmonary artery. It's important to know. Also, we look at that, you have to imagine what would be my trajectory for a transeptal, and where would I land the lobe, where would I land the disc. So it's important to plan the procedure up front before even you start the case. Now, we talked about we want to land the disc on top of the pulmonary ridge. That's the goal. But in few challenging anatomies, that may not be possible. And sometimes some people try to land the disc on the top of the ridge, and that way they deploy the lobe very shallow, and then they end up having a device embolization, and that's a problem. Also, it's been brought up earlier, you have to know that if you're new to Amulet, please do not start your first few cases with failed Watchman. It's very important to use pre-imaging. I don't pre-image anything, but if you're new to the Amulet world, it's good to have common garden varieties first 5-10 cases so you know how the device behaves, so you are more familiar about the device recoil and whatnot, and then you can take more challenging cases before you do them. We start from femoral axis. There were traditional palpation-based technique in ultrasound. A lot of people say, I've been doing this palpation all my life. All it takes is one case to change your management. It happened to me 4 years ago. Doing a Watchman, patient went to the OR. It was a disaster, and after that I changed my practice, do everything under ultrasound guided. There are numerous studies that show that ultrasound guided venous access or arterial, if you're doing some other procedure, is safe. And this is one of the meta-analysis the biggest one I could find, 8,000 patients, less chance of major vascular complication, minor vascular complication, post-procedural groin pain. That ultrasound guide access is very important. You know, I know there's a whole talk, so I'll rush through this, fast enough. For Watchman, we always had low and posterior approach. Most amulet, procedures could be with the inferior mid or mid-mid approach, can be done because of the dual seal technology. But transeptal puncture has to be planned, and there's a whole talk, so I will skip that. And obviously, if you have a very anterior chicken wing, you're going to go very low anterior approach. If you have a posterior anatomy, you're going to go more posterior and a little bit high approach on those. Steerable sheath will help some, but it is not an alternate to a bad transeptal. This is a nice paper by Bradley Knight's group from Chicago, recently came out. If somebody's new to the transeptal puncture world, we're looking at where the complications can happen. So you can, there's many different ways to do the transeptal puncture, and, depends upon what you're comfortable with and what you're trained with. And there's a traditional approach with a BRK needle, and you just go with a blunt force. Or there's a safe sept wire, which is a tiny flimsy wire, I think it's 0.14 wire, and you can use that to guide your transeptal. Or you can use, a powered needle approach in which you use electrocautery pin on the traditional BRK needle, or you can use a Baylis needle. Similarly, you can use a 032 wire with a radio frequency like VersaCross system, or you can use, what I typically do is I use electrocautery pin on the 032 wire, and I do transeptal in those cases. Now, when to give heparin, that's another question, depends upon what you feel comfortable with. A lot of people, like myself, I do full heparin before I do transeptal, because I'm using electrocautery over my 032 wire, so I don't want a clot formation on top of it. But a lot of people do a full heparin after they go transeptal, and a lot of people do half dose before, half dose after. I mean, there's pros and cons to it, depends upon which, but as long as you give heparin as soon as you go transeptal is important. This is a paper in which the four, ways of transeptal are mentioned. You have mechanical needle, you go for a needle wire approach, a powered needle approach, or a powered wire approach. Various examples of this. This is like a transeptal with a BRK needle. You can just push through it, or you can use electrocautery and then go transeptal. Or this is not my slide. This is the only I could find over the web, because I don't use safe sept wire, but this is a very flimsy wire. It just gives you a track, and you can advance the dilator over it a tad bit, and then change to a stiffer wire, and then do the exchange. And then this is how we do it. We use electrified 032 wire. We use electrocautery pin, and we are able to do transeptal with that. And this is the VersaCross system, in which you guys are familiar with. We use radio frequency over the wire, and then you can go transeptal with this route. Now, in old times, people were doing transeptal with a blunt force and were putting their 8 French sheath, the SL sheath, over the needle without any tracking guide wire, which a lot of people still do. But if you're new, I would recommend pushing the sheath over the guide wire. You can do it two ways. You can put the J wire into the left upper or left lower pulmonary vein, and this is most EPs are familiar with doing this. You can push, like this septum was a little difficult. I'm trying to push over it. It's not, even the 8 French is not going, and then obviously you can balloon the septum. That's one option too. But you can just push through it, but your distal tip is protected in such cases. Also, a lot of interventional colleagues are using Touré guide wire. You just use this guide wire and are able to push into the left atrium, and that is an acceptable alternate for this. So avoiding complication. Obviously, if it's up to us, we all want one-shot deployment, single device. That is not always the case, but still, in my cases, 80% of those are single device, single shot deployment. And obviously, you need to have a great imaging. Now, there's a lot of discussion about T is better, or CT or ICE is better. It really depends upon what your what you have available. If you have a great imager, TE would be as good. Now, if you don't have a great imager, you might want to consider ICE imaging for those times. Also, we talked about the trajectory of transseptal, and I know there is a talk about device sizing, which is important. You definitely want to compress the device, but you don't want to over-compress the device, because then you could have more pericardial effusions. Also, it's important to know the device recoil, especially if you're new to the amulet world, that there's a recoil associated with the lobe, and so you need to know at what point you want to unsheath the device so that the lobe actually lands at a perfect position. And also, I know there's a session about the complex LA anatomies, and I briefly will go over a few difficult anatomies, how to avoid complications in those things. This is my homegrown video. I made it myself. So this is like if you think you're going to land there and you just unsheath, see what happens. The device is a big recoil on it. So in which you go a little bit deeper. So once you know where the device is going to land and see it landed perfectly, that's where you want to land the device. So again, that we already discussed this. What is the difference between Watchman flex and amulet techniques? It's a different measurement, different orientation. It sits way more proximally. And in Watchman flex is pretty atraumatic, softer. You can push most of the time in a ball form. I still believe that in difficult anatomy especially, the amulet was more like an old Watchman thing. You go a little bit deeper with the sheath over the pigtail, and then you retract to a ball and deploy in those, especially chicken wing anatomies. It's more like unsheathing the device. Also, if you deploy it and you don't like the position and you want to resheath the device, it's more like a traction, counter-traction. In flex, you can just pull the device back. But in amulet, if you just pull the device back, you can shear the pulmonary artery or the appendage wall, and that can lead into trouble. So it's more like traction, counter-traction technique in those things. And we discussed about this. We have already discussed closed criteria, and we were discussing in the proctor meeting yesterday that it should be a closet criteria, because I really believe in tug testing. And the tug testing, I think, obviously you don't have to be super aggressive with the tug testing, but you have to do it one time, because if the device is loose, it will embolize at that point. So it's better to have a device pull out while it's still attached rather than at a later time. I just realized that I forgot to put some slides about air embolism, so I'm just going to talk about it. We had, there was the old steerable sheath had a valve issue, had some air embolism because of it, so that's being corrected. That's one part. The second most part is the device prep. So, some people say, oh, it's very difficult to device prep compared to Watchman. It's just a learning curve to it. A lot of times they will tell you from the IFU that you flush the device with the saline and suck it back. What I have found is when you suck back, that's when you have more bubbles come through it. So typically in our lab, what we do is we just power flush with our syringes. We never suck back through the bowl. We just go only forward. And usually it takes 350 cc syringes or 360 cc syringes to prep the device. Now the second most important time when actual air gets in is while you are trying to introduce the device into the thing. As like Chris said, patient took a deep breath, so you have to pay attention to it. It's more problematic in patients with very low atrial pressure. So you want to give fluids once you have the left atrial pressure, say very low, because in those patients it doesn't bleed. So wet-to-wet connection is very important in those patients, that you do a wet-to-wet connection, and that will decrease the chance of getting air into the sheath. Also, I know there's a whole session about it, but I'm going to talk about few. We're just writing a paper about it, and we have a lot of big series about patients who were with failed Watchman, and we implanted amulet. We had like almost close to 70 patients. Other than one patient, we were able to successfully implant amulet in all of those patients, and those were all failed Watchman flex patients. And I want to talk about each one, how to avoid complications, because these are complex anatomies. So I know we talked about there are 4 type of appendage anatomies, but this is like subtypes of those. A very shallow one, a bilobed one, a multilobed one, a shallow vertical wing, which I call it as a seahorse anatomy. And then there's another one which is an extremely oval appendage, in which on 45 you say have, and you look at 135, it's 2.5 times extreme oval appendage. Those are the ones which are difficult with which are almost impossible to close with Watchman. But again, these are also the anatomies which you run into trouble with amulet if not done properly. So this is one example, like you have a very shallow appendage, you try to put Watchman, the device is not stable and it's going to embolize, you're not going to take that position. If you have any anterior lobe, you want to try to do that, and hopefully your stabilizing wires will help you in that. Maintain forward pressure and amulet, you don't need that much of a depth. Like this patient, we did Watchman, like we attempted Watchman this patient, they're all my patients. There was a big leak and device looked pretty unstable, didn't take the position, brought him back, and we had a great amulet result in this patient. Now this is another one in which you have a bilobed appendage or a whale tail, and if you try to do Watchman, if you try to put it over the carina, the device is very unstable. But if you try to put in one of the lobes, you have leaks on the other side. Amulet strategy is, if you have enough depth, put it over the carina because it requires relatively less depth. Or if you have a big lobe, you can put it in the big lobe and the small lobe will be covered by the disc, and that you use the amulet design to your advantage. This is the same patient. If you do an angio, you see there's a double shadow on it, and that tells you there is a second one. We talked about the role of 3D, and if you look 3DT, and you can see there it's a bilobed appendage, very clearly visible on the 3D image. And this is the patient. I tried to implant Watchman, and I put a small one, it would leave leaks. I went with a bigger one, but the device was on the right images, not stable. It's more than half out, so I didn't take this position. And the same patient did amulet with this. The amulet was able to fit it over the carina, and we had a great result on this patient. Now this is the one which I think is the most scarier to cause complication. This is the one where I think I typically use like an old Watchman 2.5 technique to deploy the amulet. It's a vertical chicken wing with very shallow depth, and it's going vertically and superiorly. And this is the one which almost Watchman is impossible to land perfectly. And this is the one where I put the pigtail, and I typically go with a 12 French sheath, but obviously the deflectable sheath will have an advantage in such anatomy. And I put pigtail all the way up to the tip of the appendage. I have a floor picture of it, same patient. So I put pigtail all the way up, use 12 French, go all the way as much as I can, counterclock and go up, and you need to have a good trajectory to go up there because you're going very low and anterior. And in this case, we're able, this is the same anatomy, and this is how the Watchman was landing in the same patient. And I just put the amulet up there and just retracted the sheath, maintaining forward pressure, and were able to land amulet successfully in this patient without any leak. And then this is the one which it's not very common, but I have 2-3 patients, I don't know what you call, it's a combination of a hybrid model of a shallow chicken wing and with trabeculation. If you look at the 45 view, it's very small. And the same level, you look at 135, it's 2.5 times the size of that one. And so the problem is, Watchman is very difficult because you try to put the device, it is very unstable in the 135 view. And then in this case, we were able to put amulet in very successfully, went to the anterior lobe and were able to close it. I was not able to land the disc perfectly over the ridge, but nevertheless, we had a good result. This is the same patient. If you see I'm doing an angio, I'm not able to opacify the appendage in one contrast view. And you can appreciate, I'm doing a second shot, see how wide it is. And in 45, it is not wide at all. So and we had a good result. I did not land perfectly. I saw the patient. I did 2 months TE. We did not have any DRT. I know we're trying to avoid that acute angle, but the patient was bleeding a lot from GI, and we had a good result on this patient. And then and the broccoli shape, which everybody knows, you want to try to deploy in the biggest lobe and let the disc cover the other things. This is the Watchman, very unstable position, was not fitting in. We were able to put amulet in this without any issue. And ultimately, when you're new, I don't recommend sending the patients home same day initially. In the initial few implants, keep the patients overnight. Not a bad idea to do an echo, transthoracic echo, limited views, pre-discharge. Typically, we send our patients, majority of my patients I send home within 3 to 4 hours, but we do a limited post-op echo before them going home. If patient had, as we talked about, prior heart surgery, so you can push more, that's different. But if you had a patient with multiple deployments, difficult anatomy, without prior cardiac surgery, I recommend keep that patient overnight. I reverse heparin in every appendage occlusion case I do at the end of the case. And I empirically prescribe, colchicine and Celebrex for 5 to 7 days in very difficult anatomies, and I delay the aspirin Plavix until next morning. And we had good result with those, and we are up to, I have done almost over 290 and counting, and with this, we have very, very limited complications. Thank you so much.
Tough acts to follow. I especially like the complication talks. They always become shocking. Here are my disclosures. So originally this talk was more of a broader malposition of the appendage talk, and so I just simply wanted to point out that it's not just Watchman that leaks. There's lots of things that can leak, and we're asked to fix a lot of these things. Some of them are surgical closures, AtriClips, things like that. So when things go wrong, I actually kind of enjoy dealing with these things. This is really the case that got me started down this journey. This occurred about 5.5 years ago. And it was a patient with Watchman 2.5 that was implanted. And you can very clearly see, I don't know if this movie, yeah, you can sort of see the Watchman. You can see the flow going around it. So anyway, this was a case. So a patient got a Watchman implanted 5.5 years ago. They had leaks. They stopped the anticoagulation in spite of the leaks. And then almost a year later, the patient just happened to need mitral valve repair. And so that's when this was the first time I was called to look at this. And they said, well, what do you think? And I said, well, go ahead and do the mitral valve repair, but you might want to take out the appendage and let's take some photographs. So what we found was that although there was a thrombus that wasn't that obvious on TE, it was really obvious. It was a great big old clot on top of the device. Also, this was a 10-month-old Watchman, and you could very clearly see PET fabric. Some of it had some endocardium over it. A lot of it didn't, and you could clearly see all the blood just drained out once you took out the appendage. This is the appendage that sort of fell away from it, and this was the cavity of the appendage 10 months later. Now, this is what we found, and this was from the Protect AF trial. This was a patient that actually was a part of the original feasibility trial, and this was a 9-month-old Watchman, and the patient died of an unrelated issue, and they did an autopsy and took pictures and thought, this is just awesome, because you can barely even tell that there was a Watchman there. So why this with us, and why this here? And so we started seeing that the only common denominator that we found in the first 19 patients that we had who presented with thromboembolic events post-implant, and admittedly these were all Watchman patients, was that they had leaks. So if you're considering dealing with these leaks Secondarily, there's a lot of things you have to think about. One is, if it's a Watchman, is it a 2.5 versus a Flex? They're two very different things. Same fabric, same metal, but fewer struts on the 2.5, more of a crescentic relationship. And Amulet is completely different. Again, same fabric, same metal, but completely different configuration. How old are these things? Are they a week old? Are they a year old? Makes a big difference. Have they had prior sternotomy? Just like with a lot of some of the other implants that we've shown over the last couple of days, whether somebody has a sternotomy matters, because you're much less likely, not impossible, but less likely to have a bleeding complication from that. And then if it is a leak, what's the nature of the leak? Is it a missed lobe? Is it in the right place but just simply canted? Is it sideways? Did it migrate distally? Did it migrate proximally? Watchman Flex can migrate distally. 2.5 never did. But they can also migrate proximally. And of course, Amulet, if they're going to migrate, they tend to migrate proximally. So case one. This is a 75-year-old female AFib. Let's just cut to the chase. Okay, they needed an appendage closure device. They got an appendage closure device. And this is what was seen at the 6-week follow-up. Notice that there's a hypoechoic area distal to the device, which happens to coincide. The fabric ends right here. So there's a hypoechoic area that exactly correlates with where the fabric goes away. And depending on how you angle it, you can most definitely see color flow going around the device, in case you're having trouble with that. It measured as a 3-millimeter leak. So the initial interpretation was it was, quote unquote, a small peri-device leak. Based on the PROTECT AF data, which was 14 years earlier, it was not thought to be significant. And out of caution, they left the person on Pradaxa for about 3 more months, after which time they saw the patient in the office. And this is an actual quote from the office visit. I'll cut to the chase. The decision was to stop anticoagulation, not to look again, and to simply send the patient on their way. Exactly 14 days later, after the discontinuation, the patient had trouble speaking, had a right facial droop, had a CT without contrast showing no clot and no vascular issues with the carotids. Brain perfusion study showed something. Okay, so when we talk about, TIAs and things like that, it's kind of abstract until it's not abstract. And so this is a patient with an entirely avoidable complication that was simply not avoided out of laziness, really. So I'm not going to show you the closure of that case. I just was pointing out it's a real thing. So another case, 73-year-old AFib, again, they had a reason to get an appendage closure device. In this case, they got an Amulet. And the initial imaging, this is actually post-implant. And I believe this was one that was implanted elsewhere. There was some concern that the device was potentially not stable and might actually be at risk for embolization. When we looked at the imaging, it actually didn't look like it was about to embolize. And this was the only angle by TEE where they saw anything. I can't get this image to run, I'm sorry. But this is the disc of the device, and there's like this little sliver to the side of the device. It's kind of small. So my initial thought was, okay, everybody got all worked up from an unstable device. And yeah, it may not be completely closed, but it's not about to fall out. So, however, we were on the table, so we went ahead and took a quick angiogram. And the angiogram clearly showed a leak that was much larger than what would have been appreciated by TEE. And what was interesting and actually kind of annoying was that once I cannulated it, suddenly the imager said, oh yeah, there's a really big leak. It would have been nice to have seen this giant crescent before we actually cannulated the patient. So since we're there, since the patient had, this was actually an 8-week-old Amulet. I normally would have waited longer. We brought this patient into the lab because there was concern that it was going to need to be extracted. So the longer you wait, the more difficulty you're going to have in extracting these things. So in all honesty, I would not have taken this patient to the lab at the time that I did. But since we were there, and this was actually the fourth city that the patient had procedures related to their dang appendage. They'd had a failed Watchman, then a amulet, as you can see, and then a TE in a different city, and then finally with us, we wanted to try and put this to rest. So the way we typically close these is we use Amplatz or AVP2, which basically has no anchors whatsoever. It's got 2 discs on either end. It has a central cylinder, and it's a micro nitinol mesh, so it's designed to close PDAs and vascular issues. So it works very well, and it tends to fill the space. And what I also liked about it was that the proximal disc, we put the proximal disc in front of the amulet disc, and it kind of pulled the disc in. Now, typically in a case like this was a fairly wide defect, so we actually had to put 2 of them side by side to basically pull the disc in and fill that space. So once that was done, you can still see some contrast moving past the disc. However, we were confident looking at esophageal echo that we'd completely covered both areas, and we're fairly confident that that would close. So another case, don't want to leave this just with amulet. A 79-year-old person needed an appendage closure, got a Watchman flex. This was in 2020, so this was after Watchman 2.5, but certainly before anything bigger. And this was what I would call a Texas-sized appendage. So they decided to say, let's just go with a 35 device. Probably ill-advised, probably could have made a pretty strong argument that an amulet, the largest amulet, would have worked much better. It's not what they did, it wasn't me. And this is what happened. The device migrated distally. We see this in the undercompressed devices that have space distal to them. They tend to migrate distally. And the problem with it was if you want to try and close that, there wasn't a whole lot of space to go around the fabric. So we had to invent a new way of doing this. And so we decided to look at a royal hat, and thought that the fabric has traditionally been viewed as a barrier, but what if it's not? What if it's actually part of an anchor? And so if you use an RF needle, you can pop through it almost instantly. You do have to be careful that you're not around tissue, because it will absolutely go through tissue. And so the idea that we had was, let's puncture through. This is actually our first transfabric puncture case. And then dilate the fabric, and then use, in this case, a talisman to go inside with a disc. Has no anchors, of course, so it has to be bigger than the hole, and then have a proximal disc that covers the bulk of it. And we've done it a number of times. This particular case, I think we probably should have punctured a little bit higher, so we more closely approximated that. But the follow-up imaging actually looked closed on that patient. So definitions of leak post-appendage are actually quite confusing. If you look at all of the data, there's only 2 elements on both ends of the spectrum, which everyone agrees on. That is, big leaks are bad and no leaks are good. Thank you.
We have some questions from the audience, and the first question is, how do you treat patients with pre-existing effusion differently prior, intra, and post-procedure? Professor Frischer?
So how you treat, sorry?
Patient with pre-existing pericardial effusion, how do you treat them differently during appendage occlusion prior to the procedure, intra-procedure, or post-procedure?
Well, that depends, no, on the origin of the effusion. And honestly, if I have a severe pericardial effusion, I probably, and I don't know the origin of that, we probably stop the procedure. If we have like a moderate or mild pericardial effusion, I think that we can go. And, you know, like if it doesn't change, you know, from, you know, moderate to severe or mild moderate, I wouldn't drain it, because I think that it's also important just to see if there is a change. But I think here the key of the question is just to know the origin and if the patient is on anticoagulation or not, because if you're just giving some anticoagulation after the intervention, maybe that's going to get worse. So I think that it's important to know the origin.
Chris, how do you do that?
On a rare occasion, I've gone ahead and done like a sort of quasi-dry pericardial tap and just seen what it is. You know, like take a peek at what the fluid is, and then whether or not you need a drain in there, you know, sort of depends on your echo findings. But sometimes we'll put a drain in, go ahead, do the procedure, reverse anticoagulation. If the drain's clear, just pull the drain. So you can proceed. But it's just, you know, every patient's going to be totally different on that.
Yeah, you know, typically if we see in our lab a small effusion, a centimeter effusion, we just watch it. I typically don't discharge those patients home same day, because I just want to make sure that overnight it's not going to grow, and I do give empiric colchicine for a week for those patients. The second question is, I think this is for Dr. Horton. Is there risk for device embolism during the plugging of PDL? If so, how long after the index procedure can it safely be performed?
That's a good question. So most of the techniques that we use for closing peridevice leaks do not involve anchors. So the only way you are certain that whatever you're putting in there is not going to embolize is by using the original device as the anchor. And so if you were to do it a week later, I think that would be crazy, because the device is not stable at that point. Ordinarily, without having extraction experience, I probably would have said you'd wait at least 3 months for that. However, we have had a couple of cases where we unfortunately had to extract devices out of an intact appendage. And in that case, we try and do it as quickly as possible. And I was shocked that even an 8-week-old device, every place where the nitinol is in direct contact with the tissue is pretty adherent. So these things are actually pretty stable, and we've seen devices shift when we put in a larger device around them or through them, but we've never really seen one even come close to embolizing in that way. But yeah, if you did it right after the implant, and this does come up when I occasionally get calls from someone who has not released a device, and they say, well, what do you think about putting another device next to it? I'd say, why don't you wait and let this one stabilize, make sure, because that becomes your anchor, and you have to be sure that it's going to be stable before you try and do something.
Typically, how long you wait? Like, you know, say if you get a device and you know there's a big leak, you wait 1 month, 2 months, 3 months?
Well, okay, so it's typically what I'll do with any type of appendage closure is 6 weeks we'll do an imaging study, and there are 2 outcomes from that. It's either perfect, in other words, completely thrombosed, it looks great, or it's not perfect. And so small leaks, admittedly, small leaks do sometimes go away, only about 1/3 of the time, but they do. And so if we see a device and it's not perfect, what we will tell the patient is, look, it's not perfect, let us calm down, let's give it 3 more months, we'll leave you on anticoagulation, we'll re-look. If it's gone by then, or if it looks like it's getting smaller, we'll leave them on it even longer. And as long as they can tolerate that, that's what we typically do. It's only in the active bleeders, or we think something might be embolizing, or at risk for embolizing, that we would try and do something much sooner. But 8 weeks will work. It actually is earlier than I would like to do it, but this case was one that we kind of caught by, we were caught surprised by what we found. It was not what we were expecting.
The next question is, how little separation between the lobe and the disc will you accept in difficult anatomies or a failed Watchman case? Professor Butts?
Yeah, I think we have to follow the close criteria, and if you see that there is concavity of the inner part of the disc, I think that is sufficient. So you have to see at least a little bit of tension. It's difficult to express this as millimeters, but from the moment that you see that there is tension, you're sure that the device is stabilized. I think it's very important to follow these close criteria for stability and optimized position.
Got it. So yesterday we were discussing the same thing, a bunch of us. So the thing is, in order to look at separation, you have to go to RAO cranial view, because you may not think that there is enough separation in the RAO caudal. So if you go RAO cranial, you will appreciate that there is some separation. Also, it's important to follow the close criteria. Also, a tug testing becomes important, because the main thing is if there's not enough separation, the device could embolize, and so tug testing becomes important at that time as well.
Sorry, one comment, but anyway, like just, I think that the huge separation, it's not good, because sometimes, if not, the lobe will pull the disc. And, and that sometimes happens, that you have, like a perfect result, covering the pulmonary ridge, then you release, and the disc falls.
Yeah.
So, I mean, I'm just changing a little bit from going a little bit distal just to more and more proximal, just to avoid that kind of, unexpected movement when you release.
So somebody asked a question for me that what is comment on the safety of transeptal puncture using a 032 wire with electrocautery. I know in the paper by Dr. Knight, they showed the lesions, and they showed a big lesion when you use electrocautery with a wire. Having said that, because we're not just putting a wire, we're putting a 16 French sheath through it, so it's going to be way bigger trauma anyways, and that's why I give heparin upfront, and I'm an electrophysiologist. I've been doing ablations like the same technique for 7 years. I have over 1,500 transeptals with 0 stroke and no issues whatsoever. So I think it's pretty safe as long as you anticoagulate before you attempt the transeptal. Okay, there is another question just popped up. Upon review of pericardial effusions, is there any anatomy where you will not try implanting the device? Professor Fischer?
I haven't found, like an anatomy that I can anticipate, that I'm gonna have like a pericardial effusion. I'm going very careful, for me, like the most, dangerous anatomies are the ones that have the pulmonary artery, as Debbie showed, like very close. And also for me, like the most dangerous are these appendages that are contracting. So in a sense, collapsing, the device, the lobe of the device, it's moving, all the time. So you can anticipate that those hooks might, like be scratching, the pulmonary artery. So that, concerns me, but, doesn't, stop me,
So Chris, have you ever stopped doing an amulet procedure just because patient had an infusion and a difficult anatomy at baseline?
Yeah, last week. So I think I mentioned that case. It was probably an 84-year-old lady. I mean, equivocal appendage anatomy to take a choice of device. Anything would have worked. But when we put the TE down, it was just the contact points along the edge of the appendage were numerous with the pulmonary artery, and the patient was in sinus rhythm, and the appendage wall was extremely thin. So, I mean, I just didn't think, in that case, I'm going to risk-benefit analysis that and go with a flex. So yes, don't be afraid to do that.
Any other questions?
Maybe I have an additional question. Do you send then the patient to the surgeon to close?
Oh, so actually that's a good point.
Next step?
No, there's a lot of times I do send a patient for AtriClip, and I've had, usually it's because the thing is too damn big. It's Texas-sized appendage, and like I need to just take the whole thing out, so we'll do it with a clip. On occasion, I still do a lariat now and then, just depending, mainly just so I can keep my skills up. Yeah. But yeah, generally.
Any other questions, comment? We are ahead of schedule. We'll just take a short break, and we'll get together after that. Thank you very much.